an example of this. Or infectious causes, you do see proteinuria and post-infectious glomerulonephritis. And what happens is that essentially that this is the glomerular filtration barrier. So these are what I've depicted is the podocytes. This is the glomerular basement membrane. And these are the nephrin proteins. And if there is a disruption anywhere, there's a diffuse effacement of food processes. This barrier gets disrupted, and there is a leakage of protein from the blood compartment into the urinary compartment. Now, nephrotic syndrome, we all need to know, has got different etiologies. So, you have idiopathic nephrotic syndrome once you have excluded the secondary causes. So, you are dealing with the primary, which can be steroid sensitive or resistant. So, we'll come to the definitions later. As far as steroid sensitive is concerned, it is believed that it's due to a circulating factor, which is there in the blood, podocytic, several, the Shankland's factor has been implicated, and this causes disimmune pathology. But even today, we don't have a monogenic cause. So the importance of understanding this is that if you are ordering genetic tests in steroid-sensitive nephrotic syndrome, the yield is going to be poor because we don't have a monogenic. It is in steroid-resistant that monogenic cause genes have been identified, and several proteins are there. So we know the mutations that are there. Like in congenital nephrotic syndrome, we have the Finnish type, sublunar steroid-resistant nephrotic syndrome, autosomal dominant FSGS. Range of podocytic proteins have been identified. So, if to make it more cost efficient, it is worthwhile to do genetic analysis in the steroid-resistant group. And again, we'll discuss this later, but not in steroid-sensitive group. So that's the first message you all need to take home. Now, when you see a child like this, what first we need to decide, is this the first episode? Is this a child who's had nephrotic syndrome before and is coming with relapses, infrequent relapses? Is it frequent relapses steroid dependent, or is it steroid resistant? And there are certain definitions of this, and we'll come to this in the next slide. But if the child is coming to you for the first time with steroid sensitive nephrotic syndrome, then the KDIGO guidelines suggest that about 8 to 12 weeks of therapy with daily, starting with the 60 milligram per square meter daily, or 2 milligram per, which translates into 2 milligram per kg per day, to a maximum of 60 milligram per day. And this should be given 6 weeks daily, followed by 6 weeks alternate day. But if the child comes to you with a relapse, then a much shorter duration of therapy needs to be given. And I think this is one of the commonest mistakes that I see when patients come to me with prescriptions from outside. They are treated just like a first episode with a prolonged 6 weeks. No, you just need to give 60 milligram per square meter daily till the child goes into remission, followed by 40 milligram per square meter alternate day for the next 4 weeks. Again, there is certain newer evidence that children with frequent relapsing and steroid-dependent nephrotic syndrome who are on alternate day steroids or are off steroids, often you see they come to you with a URTI and they have a relapse. Now, you don't need to give the full dose at that point of time or the full course. Just give them 0.5 milligram per kg per day daily during the episodes of URTI for about 5 to 7 days. And a lot of these children go into remission, and the level of evidence is 1C with this, and thereby, you are sparing them with prolonged courses of steroids and the steroid side effects that are there. Now, when these children walk into your clinic with their parents, the first, question is that, can we predict, or which are the difficult patients? Can we outdo these gentlemen on the street? And the answer is yes. There are certain clinical markers, certain histopathological markers, and also genetics now is coming in a big way. Let's look at clinical features. So age of onset, if it is under 4 years, more than 8 years, then these children tend to do poorly. Our own study published way back in Ectera Pediatrica showed this. Males tend to do poorly than females. If there is a combination of hypertension and microscopic hematuria, again, these children need to be looked at in much greater detail. Hypertension isolated is not uncommon. 22% of nephrotic minimal change disease can have hypertension. Similarly, microhematuria isolated can be seen in about 20 to 30% of minimal change disease. And obviously, if you have biopsied these children and there are non-minimal change lesions, then again, that also portends a difficult course. You can straight away tell the parents. So if you have any of this, and then another factor which was found in this landmark study published in CJAS in 2013, very relevant today, even 20 years later, is if the time to remission is more than 9 days. So you put them on daily steroid, there's no infection, and beyond 9 days, the child continues to have proteinuria, and this child is in for a difficult time. Or you have stopped therapy and the child comes to you with a relapse in the first 6 months, then again. So this is how we classify these children. You subject them to standard prednisone therapy, that is about 12 weeks, 6 weeks daily, 6 weeks alternate day, and then you can stop and then see. And so about 30% of children are non-relapsers. They'll not relapse, and you're really lucky if you get to see these because they rarely come to us. They're mainly managed by the pediatricians. 10 to 20% are infrequent relapses. What is the infrequent relapser? Less than 2 relapses over 6 months. Frequent relapses, 20 to 30%, which is more than 2 relapses over 6 months. Steroid dependent relapses while on steroids or within 2 weeks of steroids. Steroid resistant, no weak remission following 4 weeks of prednisone therapy, which is completely different from adults where we are using 4 months of prednisone therapy as a definition of steroid resistance. And we'll come to that why the definition is different. Again, these are further initial non-responders or primary steroid resistant or secondary steroid resistant. What are secondary non-responders or secondary steroid resistant? Patients who have responded initially but who failed to respond during subsequent relapse. And it has been shown that these tend to have a better prognosis than the primary steroid resistant patients. So this is what the KDIGO I just picked up from the KDIGO 2021. Steroid sensitive nephrotic syndrome, complete remission after 4 weeks of prednisone or prednisone at a standard dose. Infrequent relapses, less than 2 relapses at 6 months, within 6 months of disease, or 4 relapses over 12 months in any subsequent period. Frequent relapses, as I mentioned earlier in our study, still, so all those definitions which we proposed in our are still very relevant today. More than 2 relapses per 6 months, within 6 months of disease onset, or more than 4 relapses over 12 months. Steroid dependent nephrotic syndrome, 2 consecutive relapses during therapy with prednisone or within 15 days of stoppage of prednisone. So if the child is on prednisone, he relapses, you increase the dose, comes back to you, remission, again relapses when you reduce the dose within 2 weeks or stop or has stopped within 2 weeks, and it within 2 weeks of stoppage relapses, this is steroid dependent nephrotic syndrome. The reason for this is that both these groups will require steroid sparing therapy. So whereas the infrequent relapses you would just manage with repeated doses. And steroid resistant nephrotic syndrome, no remission following 4 weeks of prednisone with daily prednisone at a standard dose. There's also a late responder, which is complete remission occurring at 6 weeks. So it's at 4 weeks you do steroid, classify him as steroid resistant nephrotic syndrome, maybe do a biopsy, but by the time he comes back to you later, to your great relief, this child has responded. Then there is CNI responsive steroid resistant nephrotic syndrome, which is defined as partial remission after 6 months of treatment or complete remission after 12 months of treatment with the CNI at adequate doses and levels. Even today, I got a patient, who was on cyclosporin. No cyclosporin levels were measured. The patient was obviously not responding to CNI, and he was labeled as CNI resistant. But in the absence of levels, you're not sure whether the levels are appropriate or not. And so CNI resistance would be absence of partial remission for at least 6. Here also, you need to make sure you're given 6 months of treatment with the CNI at adequate doses or levels. Levels, I think, is the key, and we'll just come to that later. Multi-drug resistance steroid resistant nephrotic syndrome. New definition again. Absence of complete remission after 12 months of treatment with 2 mechanistically distinct corticosteroid sparing agents at standard doses, which means you're using both CNI with mycophenolate. And secondary steroid-resistant nephrotic syndrome, I mentioned to you earlier, a steroid-sensitive patient had disease onset who had subsequent relapse failed to achieve remission after 4 weeks of therapy with an adequate dose. So these, I think, need to be, remembered when. Now let's look at the histopathology. So histopathology in children varies from minimal change disease to FSGS, and it is believed that there are different ends of the same spectrum of the disease. So if you have minimal change, it is more likely to be non-relapsing, infrequent, frequent relapses, steroid dependent, and steroid resistant, more often FSGS. 90% of these, patients are steroid sensitive, and this is of prognostic value. And although the etiologies may be, different, the treatment protocols by and large are the same. So these are the 3 common causes of nephrotic syndrome in children. You have minimal change disease. So this is a light microscopy showing a normal looking glomerular capillaries, normal looking interstitium. This is an electron photomicrograph showing diffuse effacement of food processes, which is the only change that you find in minimal change disease, but you don't subject all of them to electron microscopy. And we'll discuss that later, time permitting. And this is focal segmental glomerulosclerosis. As you can see in this area, there is an element of sclerosis that is there. Now, this is a study published in Lancet 2003. Studies from quoting studies from different parts of the world: Saudi Arabia, North America, Hong Kong, USA, including our study from SCPGI Lucknow, where over 2 different time periods, the prevalence of FSGS was found to have increased. So FSGS is increasing. We are still not sure whether the cause is infectious or is it environmental toxin, but histopathology data will also tell us it's far more common. Again, certain genetic markers have been looked at. These are a study published in Pediatric Nephrology looking at HLA markers, and we did identify certain HLA markers, but of course today, we are talking about several genetic mutations or this is a table that is there in most articles. So this is autosomal recessive inheritance, autosomal dominant. There are certain syndromic varieties, and these are the various proteins, and the number keeps on increasing. Currently, more than 50 mutated genes have been identified in hereditary nephrotic syndrome. Now, looking at immunosuppression in children, we have a few agents. We have alkylating agents, out of which include cyclophosphamide and mycophenolate. And then you have the CNIs, which means tacrolimus, cyclosporin, and levamisole. And even today, alkylating agents give you the best bang for your buck. 50% reduction in the risk of relapse for 1 to 2 years during and after treatment. And the benefit is sustained. So that is why in frequent relapses, steroid dependent, I think these are still the first line rather than CNIs, because CNIs, we all need to remember, are nephrotoxic and we can't give them beyond a certain agent. So make sure that your initial choice is right. Levamisole is another agent that has been used in children. It is a deworming agent, but it has been found to be beneficial, at least in the frequent relapser patients. So for steroid-sensitive nephrotic syndrome, the various drugs are levamisole, as I showed you. We give in 2.5 milligram per kg alternate day. The advantage of this drug is it's very cheap, no side effects, very well tolerated. And we can give it, if these patients are doing well, we can give it anywhere between 1 to 1.5 years and minimal side effects, and especially in frequent relapsing children. It's a great drug to use, more so if the child is under 2 years of age, where there is hesitation in using cyclophosphamide. And cyclophosphamide, again, as it shows, not recommended in the first 2 years. 65% remission at 5 years. Even today, this is one of the best remission rates. So very important take-home message that cyclophosphamide, is the cheapest and one of the most effective drugs, as a second-line agent in steroid-sensitive nephrotic syndrome. More so if these patients are steroid-dependent, because 50% of these patients achieve permanent remission. The usual dose is about 2 milligram per kg per day for about 8 to 12 weeks. The maximum dose you need to remember should not be more than 200. Better to stay at a lower dose of about 178, which there is a consensus. And you can use repeated doses in females, but best avoid it. Another alternate way to use cyclophosphamide, which has been studied by a group from SCPGI, and we have published this, is that this is an index case, just for your reference. A 7-year-old child who had steroid-dependent nephrotic syndrome came to us in 1993. We gave him monthly pulses for 6 months, and as you can see, had one relapse 1995, and thereafter went into a sustained remission. So we call it a come in, get it, and forget it approach. And during cyclophosphamide, the child can be busy either playing on the laptop, some games, or on the mobile, just to keep him occupied. Typically, the infusion is given over 3 to 4 hours to avoid nausea and vomiting. And this is a study which was published in Nephrology Dialysis Transplantation with, as you can see, in the steroid dependent group, after a mean follow-up of nearly 4 years, complete remission was seen in 42% patients. 31% of these improved, became infrequent relapses. Another 17% improved frequent relapses. 10% did not respond. In frequent relapses, results are even better. 68% complete remission. 18% of these patients infrequent relapses. 14% continued not responding. Continued to be frequent relapses after nearly 3 years. Mycophenolate, a very popular drug. In fact, a lot of these parents, when they come to you, they read up, they are worried about gonotoxicity, and they say, and in my practice, it's always a joint, decision between the parents and myself. So we tell them about both the drugs. We tell them about mycophenolate. That advantage is that, it is, the side effect profile is very good. It acts by inhibition. I'm sure you all know that. Inhibits the enzyme IMPDH and inhibits B and T lymphocyte proliferation. The dose you need to remember, you need to have the body surface area ready of the child. So 1200 milligram per square meter daily in 2 divided doses. And Hogg's study showed that 25% of the frequent relapsing children attained a sustained remission. So I think a very useful drug in this. But steroid-dependent nephrotic syndrome experienced by Dr. Baga's group also shows that these children tend to relapse soon after stopping therapy. Our own experience is also not too great, and that's why we counsel the parents that this patient, we might, if this is a steroid-dependent child coming to me, I tell them that better opt for cyclophosphamide. But many times the parents say, no, we'll want to have a go at this because of the side effect profile. But essentially, the biggest role of this or utility of this drug is in patients, whom you have used CNI, and these children tend to become CNI dependent. And then every time you withdraw CNI, these children tend to relapse. So what you do is you add MMF. Under cover of MMF, you withdraw the CNI agent. And first highlighted in the landmark study by Ulinsky et al. But again, I'll share with you this index patient presented to us at 2.5 years of age. We biopsied him. He had mesangial proliferative glomerulonephritis, obviously IgA negative. We put him on cyclosporin because he was steroid resistant. 5 milligram per kg, and for 2 years he attained remission. But every time he wanted to withdraw cyclosporin, this child used to relapse. So he became cyclosporin dependent. So at this point of time, we added mycophenolate, and after giving it for a few months, he started reducing cyclosporin. Finally, stopped cyclosporin. Then after 6 months of giving mycophenolate, we stopped mycophenolate, and this child attained a sustained remission. So summing up the management of steroid-sensitive nephrotic syndrome, we need to prevent relapse occurring with prolonged initial therapy, treat the initial or rare relapses with shorter courses of steroids. Then for frequent relapsing of steroid-dependent patient, use levamisole or cyclophosphamide. If the child is steroid-sensitive but steroid-dependent, consider low-dose, long-term. This is an alternative protocol. You need to keep in mind patients who are relapsing despite agents used earlier. Some times you can use 0.25 milligram per kg alternate day therapy or intermittent cyclosporin plus tacrolimus with steroids. Rituximab is another drug, can be used as a rescue therapy in patients with steroid-dependent or cyclosporin-dependent nephrotic syndrome, where you've exhausted all, drugs. So we use it typically 2 doses, 750 milligram per square meter at an interval of 15 days, or 500 milligram per square meter every weekly for 4 weeks. Now, nephrotic syndrome is a disease which is stressful not only for the parents but also for the treating nephrologist. And this is a quote from Louis Pons, a very famous pediatrician, who said that few diseases tax the resources of the practitioner so extensively as the nephrotic syndrome. You must be a combination of an infectious disease expert, nutritionist, physiologist, psychiatrist, pediatrician, and nephrologist for the patient, and above all, guide, counselor, and friend to parents. And this is a study which was published in Pediatric Nephrology 2022 regarding the perceived family impact and coping mechanisms of caregivers of children with nephrotic syndrome. And they concluded that taking care of a child with nephrotic syndrome has an impact on families and on caregivers' coping mechanisms. Nephrotic syndrome also has a higher impact compared to some other pediatric chronic disorders. Again, so caregivers should, need to be counseled, and many times, we act as counselors in our day-to-day practice. Again, here, as you can see in this study, tacrolimus use was significantly associated with perceived family burden, possibly because of the cost also, because there, you remember, in the international market, cyclosporin is available only as an innovator brand. Now, moving on to steroid-resistant nephrotic syndrome, and this is a definition of the Indian Pediatric Nephrology Study Group. I happen to be a part of this. And we define steroid-resistant nephrotic syndrome as no remission following 4 weeks of prednisone therapy, which is also now KDIGO also has taken up this definition, mind you, in absence of underlying infection, because infection can cause apparent steroid resistance. And this is the adult definition: 4 weeks, no remission following 4 months of prednisone therapy. Now, why are these two definitions? Why are they different? And the reason is not difficult to understand. So this is weeks from starting corticosteroid therapy, and this is the cumulative percentage of patients with complete remission. Now, if you look at the top graph, this is a study. This is the landmark ISKDC study, and the others are studies done in adults. So most of these children, who are responding, will respond within 4 weeks. Between 4 and 8, there is a very small percentage of patients, and certainly a small number beyond 8 weeks also. So generally, because we are not biopsying these patients prior to starting steroids. That's why at 4 weeks we generally counsel these patients that you are steroid resistant, so that we can convince them for the biopsy. In contrast, in adults, as you can see, there is a slow progressive improvement in the response rate right up to 16 weeks. So the first three are the pediatric, the first two are pediatric studies. This is the adult study. And that's why beyond 4 weeks, since we don't have a biopsy diagnosis, we will not know what we are treating. And that's why we tell them that please go ahead with the biopsy. Now, this is histopathology. This is from the landmark ISKDC study. ISKDC stands for International Study for Kidney Diseases in Children. The first, multi-centric international study done years back. And these are the different causes. Minimal change was the commonest, followed by focal segmental glomerulonephrosis, mesengiocapillary glomerulonephritis, diffuse mesangial hypercellularity, and this is membranous nephropathy. This is our own study. This is 103 patients of steroid-resistant nephrotic syndrome. This is 136 patients which I did when I was at SCPGI Lucknow, published in Indian Pediatrics. And as you can see, we compared our results with the ISKDC, and we found that 80% of these patients in our steroid-resistant patients in our experience had FSGS. So this is what we are seeing. Again, diffuse mesangial hypercellularity is slightly more common. Minimal change essentially is similar, but this mesangiocapillary is coming down. And we had a very small number of membranous nephropathy, roughly around 4% is what we found. Now, this is about, we are talking now steroid-resistant nephrotic syndrome. So this is another index patient I have taken from my practice. This is a girl who came to us at 16 years of age, and she did not respond to 4 weeks of prednisone, so labeled as steroid-resistant. We biopsied her and minimal change disease, and we gave intravenous cyclophosphamide. At that point of time, we really had only cyclophosphamide and cyclosporin, innovator brand was available, very expensive. So we tried intravenous cyclophosphamide based on our experience with in steroid-dependent nephrotic syndrome, monthly pulses, and along with oral prednisone, which was tapered and stopped by 3 months, and to a great relief, attained remission, which has been sustained right up to 30 years. So the last follow-up, I remember she came for a social visit. She had got married, I had a child, and it was very rewarding to see her 14 years later. No side effects, excellent growth, and normal family life. This is a controlled trial published by a group when I was at SCPJ Lucknow, comparing oral with intravenous cyclophosphamide. 100% of these patients in the intravenous cyclophosphamide responded. Steroid-resistant minimal changes as compared to 25% in the oral cyclophosphamide group. As you can see, 40% lower doses, minimal side effects, just vomiting or nausea. And even today, intravenous cyclophosphamide, you may not find it in the KDIGO guidelines, but it certainly finds a mention in IPNA guidelines, the International Pediatric Nephrology Association, especially for resource-limited countries and more for minimal change disease, where cyclosporin and tacrolimus are unaffordable. And this is another child we used. This child had FSGS, and we used a slightly modified protocol, a higher dose with intravenous cyclophosphamide, and we published this in Indian Pediatrics, 750 milligram per square meter, 65% remission rate. So lower remission rate as compared to the minimal change group. Again, I suspect that a significant number of them would be having mutations. At that time, we didn't have the luxury of no genes were identified and no genetic studies were available. When we compared, yes, it was definitely more economical than the innovator brand of cyclosporin. And what we also observed was that if the child was secondary steroid resistant, then they had a much better chance of responding to IV cyclophosphamide if they had FSGS as compared to primary steroid resistant, where the response rate was down to 30% only. Now, this is another patient who came to us at nearly 11 years of age, steroid resistant, biopsy with proliferative glomerulonephritis. We tried intravenous cyclophosphamide, 6 doses, no response, cyclosporin, no response. And at that point of time, tacrolimus had just been available in the Indian market, and we were using it in transplant patients. There were anecdotal reports of its use in nephrotic syndrome in adults. And so I used a dose of 0.2 milligram per kg, and to a great relief, within 4 months, he entered remission. Urine protein creatinine ratio decreasing from 7 to 0.27. And after a couple of many remission, I stopped the therapy at 6 months, and he relapsed. But thereafter, we learned how to use this molecule. And this is our article published in Nephrology Dialysis Transplantation, one of the largest and the first few studies, 22 patients with steroid-resistant nephrotic syndrome, mean age of onset 7.33 years. 84% of these patients had a complete remission, 11% partial remission, 5% did not respond. The mean time to achieve remission, mind you, was for 2 months. So you have to be patient and persistent. He's not going to respond within 2 weeks or 3 weeks. So as you can see, some of them responded even beyond 3.5 months. The mean dose was 0.818 milligram per kg. I'll come what the current guidelines say, tell you how to use this. And the mean duration was 290 days. This is a comparison. Okay, this is by Dr. Baga's group, a multicentric study looking at our 2 protocols, 131 patients, comparing 66 in the tacrolimus arm, 65 in the cyclophosphamide arm, randomized to receive tacrolimus for 12 months or 6 monthly infusions of intravenous cyclophosphamide along with alternate day prednisone. And the complete remission rate was significantly higher with the tacrolimus, 52.4% versus a lower response rate with the intravenous cyclophosphamide, 15%. Again, what we need to realize is that, as you can see here, tacrolimus had more of minimal change disease than FSGS. So more difficult, more easy patients in the tacrolimus arm, more difficult patients in the cyclophosphamide arm. So, higher incidence of FSGS in the cyclophosphamide. Nevertheless, there's no doubt that tacrolimus is currently it's more effective, but I personally feel that IV cyclophosphamide retains its place in minimal change disease. This is another study from China comparing intravenous cyclophosphamide versus tacrolimus in FSGS patients, and they found that it had a similar efficacy. But as if you look into the KDIGO guidelines, and I'll come to that, there's no doubt that CNIs are the drug of choice. Rituximab, was touted as a drug for steroid-resistant nephrotic syndrome. This is a multicentric study by Toulouse et al. From US, published in Pediatric Nephrology. 27 children, 22% complete remission, 22% partial remission. A subsequent study by Magnesco et al., not at all encouraging. 15 patients, 15 controls, 3 patients in each group, responded. So essentially not different. And this is from Dr. Baga's group, again showing that the benefits of rituximab therapy are limited in patients with steroid-resistant nephrotic syndrome, particularly those with FSGS. So it's not an innocuous drug, it has long-term side effects, and therefore we have to be very cautious, at least, and use other therapies. Combination therapies have been used, yes. Cyclosporin, MMF, intravenous cyclophosphamide, TAC, MMF, prednisone, rituximab along with MMF, and along in the nephrotic syndrome. And this is another patient I'd like to share with you. Came to us in 1993 when I was at faculty at SGPGI. Onset of nephrotic syndrome at 4 years. Did not respond to steroids. We biopsied him FSGS. No response to cyclophosphamide. No response to cyclosporin. So if this child were coming to me today, I would, do a genetic mutation. But at that point, we didn't have the luxury, so I just put him on enalapril. Later, losartan became available. So we added losartan into a great relief with the combination therapy, which is very unlike the on-target trial, which is, cautioned against combination therapies. We call it the dual blockade, but mind you, that was done in adults in diabetics. A lot of them had heart disease, AKI. This was in children with nephrotic syndrome, much stronger hearts, no comorbidities at all. And this child, I last saw him 16 years later. He was, attending college, continued on these drugs, and was protein free. So some other studies with this dual blockade has been used in congenital nephrotic syndrome, also in idiopathic membranous nephropathy. So a worthwhile, trial, especially if you have a genetic cause there. Again, this is just to give you a quick recap of the various protocols. This was the first protocol that was used. I have not discussed it here because it's been given up. It was popularly known as the Mendoza's protocol, which is intravenous methylprednisone, oral cyclophosphamide, oral prednisone given over a period of 2 years, largely, and 66% remission rates. Our own protocol of much shorter, 6 months of cyclophosphamide, oral prednisone, comparable remission rates. Cyclosporin and oral prednisone, 40 to 50% remission rates. TAC and prednisone, which I showed you in our study, 70 to 80% remission rate. As you can see from a quick review, this gives you the best response today, and that's why it's the gold standard for therapy of steroid-resistant nephrotic syndrome. Rituximab, 44% remission rate. I showed you by Toulouse et al. Half of these are partial remissions. And this is what the KDIGO guidelines tell us. Based on whatever I showed you, we recommend using a CNI as initial therapy for children with steroid-resistant nephrotic syndrome. So if you have biopsied these children, if you find it is steroid-resistant, then CNI is what these guidelines tell us. Again, don't stop. Minimum of 6 months should be given. And if there's a partial or complete remission is not achieved, you can stop it. But if these children get into a remission, then for 12 months at least, and a low-dose corticosteroid therapy should be combined. So despite it being called steroid-resistant nephrotic syndrome, we use a combination of steroids at least initially, which is then tapered off. Again, ACE or ARBs are used, and in children who do not respond to CNI, you can use, this is what the guidelines tell us, mycophenolate, high-dose or corticosteroids, or a combination of these agents. Some of these children will get into partial remission, but they rarely get add a CNI, and you can do that. Now, no talk will be complete without a word on genetic testing, because it is easily available now. So what is the role? Well, it helps us in making a diagnosis when non-podocytic diseases may mimic steroid-resistant nephrotic syndrome. So look for extrarenal features. If you're finding extrarenal features, then straight away, we could do it even at the first go. It helps us in providing genetic counseling for monogenic diseases, issues of incomplete penetrance, issues of intra-allelic influence of mutations. Again, it helps in avoiding inefficient immunosuppressive therapy with potential side effects. Again, here there are studies which have showed that even with genetic causes, you can get a partial or complete remission with CNI. So, but yes, you can spare them steroids. Again, it helps us in discovering personalized treatment. So if you find a mutation which codes for the CoQ10 protein or anticoagulant or chaperone, then you just give CoQ10 supplements and you can get a dramatic benefit. Predicts a low risk of recurrence. If you identify a genetic mutation, then you can safely withdraw all therapies if the child is not responding. And the good part is that if this child progresses to stage 5 chronic kidney disease, you can tell the parents that at least recurrence risk is negligible in this subgroup of patients. Most of these patients with FSGS, which you will recall, actually have patients who have steroid sensitive nephrotic syndrome, who have had a steroid dependent course. Also helps in selecting potential intrafamily kidney donors. Again, when to use genetic testing. So studies have shown that disease-causing mutations can be identified in 80 to 100% of patients with congenital nephrotic syndrome, even in the absence of family history. So nephrotic syndrome, in the first 3 months, the practice has changed. Instead of subjecting them to steroids, first do a genetic mutation, because whatever you might do it, while it's an invasive test, biopsy, this is a simple non-invasive test. And for other children, it is useful in childhood onset steroid-resistant nephrotic syndrome. So if they are not responding to steroids, even if there is no family history, you would subject them to genetic mutation, which means 4 weeks of non-responsiveness and perhaps a biopsy also. Indications for biopsy: all children with steroid-resistant nephrotic syndrome. Atypical features are there. If there's a combination of hypertension, microscopic hematuria, congenital nephrotic syndrome, especially if onset is between 3 to 12 months. First 3 months, I told you, genetic studies should be the first test. Syndromic child, if the child develops AKI, again, this was and no role in steroid dependent and frequent relapsing nephrotic syndrome. Commonly, I find referrals from different physicians or pediatricians saying that he's a steroid dependent nephrotic syndrome. I don't biopsy them because I know that I know what to use. It's just essentially a decision between me and the family whether I use levamisole, cyclophosphamide, MMF, or even CNIs. Again, this is one of our earlier studies looking at metabolic bone disease in children with nephrotic syndrome. And we found, we screened 100 patients. Essentially, all of them had some degree of osteopenia. 8 of them were symptomatic, none had fractures. 29% had severe osteopenia, defined as a bone density score of which is below the -2 standard deviation. Other 71% had mild osteopenia. This is a follow-up study on these children. We subjected all them to calcium, phosphorus, PTH, alkaline phosphatase, DEXA studies periodically. All of them were given calcium and vitamin D supplements. And what we found was there was a significant improvement in these children who were given calcium and vitamin D supplements. And this again has found its way in the IPNA guidelines 2022 that all children with nephrotic syndrome should be concurrently given calcium and vitamin D supplements so to prevent osteopenia, which is easy prevented than treated. The way to look at is using DEXA study. It's an slightly expensive test. So simple ways to just give them calcium vitamin D. Again, this is studies in telemedicine. We found that it is excellent in managing patients with nephrotic syndrome. This was during the COVID time. This is published in Pediatric Nephrology. This is again published in JIMA. Again, it helps us in triaging patients. Many times these families, this is in the post-COVID period, we continued using telemedicine, and families are hesitant because it costs a lot of money on top for the parents to travel distances. And often their travel costs are more than your consultation costs. It's a cost-effective and time-saving measure to use telemedicine and select out patients, who might require a biopsy or second-line therapy. You can immunizations, I think, very important. So all these children should be given pneumococcal vaccination because they lose proteins in the urine, and pneumococcal infections and gram-negative infections are the two commonest infections. Annual vaccine and influenza vaccines. Again, defer vaccination with live vaccines. And this is important because the school-going children, they commonly you have mass polio campaigns, and we found that inadvertently they get polio. So we write it in capital letters that they should not be given oral polio vaccine, and certainly even the varicella vaccine until the prednisone dose is below 1 milligram per kg or 2 milligram per kg on alternate days. Live vaccines are contraindicated in children receiving corticosteroids, immunosuppressive agents like mycophenolate or CNIs. Just share with you another case, came to us at 1 year of age. We biopsied him, he had steroid-resistant nephrotic syndrome, he had minimal change disease, so we used our intravenous cyclophosphamide protocol. So it did improve. I mean, he became from steroid-resistant, he became steroid-dependent. But since we had, reached the gonotoxic dose, we had no options since he was becoming steroid dependent, still steroid dependent. We used mycophenolate, he improved, became frequent relapses. For mycophenolate, he continued to have frequent relapses. And thereafter used levamisole, and then he became infrequent relapser. Now has attained sustained remission. But as you can see, his height has been well preserved with early use of steroid-sparing agents. So gone are the days we give them endless repeated courses of steroids. People are already talking of steroid-sparing regimens in glomerular diseases. And again, we should also, at least in the frequent relapsing steroid-dependent group, quickly move on to second-line therapies. That's why it's important to remember the definitions that I shared with you earlier. And this child then came to me later on, years later, 12 years later, as you can see, height at 10 centile, which is not bad for a child who had nephrotic syndrome at 1 year of age. Prognosis, 80% have minimal change disease. Prognosis is generally good. 90% are steroid responsive. 70% have a relapsing course. 80% have a long-term remission during childhood. But very important for you all, 15 to 20% will graduate into adults who will continue to have nephrotic syndrome. So you will be seeing, even in your adult practice, you'll be seeing these children, and it's very important to look at their diaries. We call it their treatment diaries, and we encourage all of their parents to maintain these diaries. So you'll see which are the drugs that have been used. Be very cautious. Invariably, cyclophosphamide would have been used. You don't want to, subject them to gonotoxic drugs. If lot of steroids have been used, try and look at their bone densities. Mortality rates have come down. Sepsis and vascular thrombosis are the two. Prognosis is poor in steroid-resistant and non-minimal change disease lesions. So if you see a child with nephrotic syndrome, first of all, make sure it is idiopathic. Look for secondary features by clinical features as well as investigations. Confirm is idiopathic. No need to subject them to biopsy at the onset. Subject them to standard prednisone therapy for 4 weeks. If the child is responding, continue to 6 weeks, followed by 6 weeks alternate day. And referral is required. Get a pediatric nephrologist involved, or you can do it yourself if you are comfortable. If you're having atypical features for biopsy, frequent relapses, steroid dependent, and requiring second line agent, steroid resistant complications. And this is, I was a faculty at McMaster Toronto. This is my senior colleague, and this is Jackie, our nurse, who was a specialty nurse with her daughter. And this is Jackie's picture when she was 4 years of old. And she had nephrotic syndrome. So managed very well by my senior colleague. And as you can see, Jackie's height is well above the height of an Indian average female. And the trick is to use early second line agents, avoid the toxicities with steroids. And I think, this is a chapter in the IEP textbook of pediatrics where I've authored a chapter on steroid-resistant nephrotic syndrome, also published a book on childhood renal disorders. And if there are any questions, I think we come to a close and I'll be happy to take them. Over to you, Puneet.
Thank you so much, sir. We can have some questions, sir. We can have questions in the chat box, or anybody can unmute themselves and ask.
So no questions mean only two things. Either everyone has been sleeping or not listening, or the clarity has been too good, which I don't believe. So anyway, that's jokes apart. But if there are any questions, we rarely discuss nephrotic syndrome in our bedside. That was the reason of taking up childhood nephrotic syndrome.
So thank you so much, sir, because otherwise, as you said, we didn't had a case. And so you've given your time and then now this lecture also so much, sir. And I think we have one question in the chat box, sir.
Yeah, just read it out for me.
Yes, sir. One is dose calculation per kg or body surface area.
I think very practical question. So, in younger children, under 2 years of age, there is a difference. So, you can start off with a 2 milligram per kg dose, but if you're seeing that at the end of 1 week, the child is not responding, try and look at the body surface area and make sure, and you'll find that there is an increment of about 5 milligrams roughly. That is what I have observed. So, because as I told you, beyond 9 days, if they are not responding, they'll not, that suggests a poorer outcome. So in older children, by and large, we have not found any difference whether you do a body surface area calculation or, as I said, and the maximum dose is anyway 60 milligram. So let's say you have a 30 kg child, whether you do 2 milligram per kg or 60 milligram per square meter, which works out to 1/8, there's no difference. So in younger children, yes, do a body surface area. How to go about collapsing? Yeah, we'll just take that question. Where did that disappear? Yeah. How to go about collapsing glomerulonephritis? Biopsy proven. Okay, so I'm assuming that this child has got steroid-resistant nephrotic syndrome. You have treated for 4 weeks, and it is a variant of FSGS. So look for all secondary causes of FSGS by serology, and have a go at tacrolimus. That is the way to treat. Next question: oral endoxin for 3 months in steroid-dependent frequent versus monthly IV endoxin. Okay, so you could use either. The advantage of intravenous monthly cyclophosphamide is that you end up giving about a 40% lower dose. You can also prolong it over the next 6 to 9 months. Otherwise, so it's just a matter of personal choice. But the advantage is lower doses of cyclophosphamide, certainly. And if you are ending up, even giving a second course, you can give a second course, whereas once you have given a 3 months course, you can't give a second course. Difficult to classify steroid dependent by old records. How to manage? A good question. So a child has come to you, doesn't have records. Quite seen very commonly we see, especially rural people. So I would then, take it up as a fresh, make sure, give 4 weeks of steroids myself, especially if they don't have a urinary report showing you remission of proteinuria, because you are not sure what kind of dose has been used. A lot of internists, or even I've seen prescriptions from qualified nephrologists, they use 1 milligram per kg daily in children, which is an inadequate dose. So give it yourself, monitor him, look for infections. How to monitor patient on long-term tacrolimus more than 6 months in steroid-resistant nephrotic syndrome? Yes, periodic tacrolimus levels have to be done. Periodic kidney function tests need to be done. Again, if the proteinuria has not changed in 6 months, just stop. If there is an improvement in proteinuria, then continue beyond 6 months. How do you use levamisole? How do you dose 2.5 milligram per kg alternate day? Yes, and withdrawal is, yes, after 12 to 18 months we stop. Toxicity to monitor, I think the only thing that you need to keep in mind is that leukopenia in a subgroup of patients do a CBC, and it can cause some skin reactions, but other than that, essentially nothing. Induction, 4 weeks versus 6 weeks in minimal chain disease. Good question. Yes, there are studies now coming up with 4 weeks doses of prednisone, 4 weeks daily, 4 weeks alternate day. We call it an 8-week protocol. And the guidelines have kept it a bit labile, 8 to 12 weeks. And if the child is gets into remission after 4 weeks, is showing steroid toxicity, you could switch over to alternate day. Use growth hormone, any guidelines? So yes, growth hormone, in steroid responsive nephrotic syndrome or steroid resistant nephrotic, because the cause of growth failure is predominantly steroids. So that's why there is no role of growth hormone. And we do see prescriptions by endocrinologists. I think they're totally off. I would just use steroid sparing agents and attempt to get these patients off steroids. So when to use rituximab in podocytopathy in adult? Again, I am not sure what you mean by podocytopathies. When you're treating with an adult with nephrotic syndrome, obviously you biopsy these patients first, and then you start steroid, which is completely different from what you use in children. And if it's a membranous nephropathy, we use 1 gram, 2 doses at an interval of 15 days is what I prefer. Again, a similar dose can be used if you have minimal change or FSGS. Yeah. So I think that brings us pretty much to the end of. And Puneet, over to you then. But I think we take leave then.
Okay, sir.
All right. I think we call it a day then. Bye-bye.
Leave.